So this is discussing ketogenic metabolic therapy as a novel adjunct to standard of care for a number of different cancers, but of particular interest to me are gliomas, glioblastomas, and cancers of the central nervous system. So I'll be doing a brief introduction, rediscussion on the metabolic theories of cancer, and going through some of the studies and case reports, mostly to do with glioblastoma, and discussing some of the human trials that are going on as well around the world. So the metabolic theory of cancer, this is a challenge to the somatic theory of cancer, the idea that cancers are derived from genetic mutations solely, and this is the main driver of cancer. There are a few problems with that. First and foremost, there is an absence of mutation in some cancers. There are some cancers that don't have any gene mutations whatsoever, and there are other tumors that may have heterogeneity between their cells. So some will have the genetic changes, some will have different genetic changes, some will have no genetic changes, and yet they all behave in this malignant way. There are cancer driver genes in normal cells, not just in cancer cells. Some carcinogens don't affect the genes. They don't cause gene mutations, such as asbestos. Cancer is very rare in animals in general, especially animals in the wild or animals in the zoo being fed their normal diet. Chimpanzees, for instance, there are no documented cases of breast cancer in chimps. But then you start seeing more and more cases of cancer when an animal is not fed what it's supposed to eat, such as our domesticated pet population, where the cancer rates are increasing dramatically. So that suggests there's more of a metabolic, environmental irritant or factor that is at play here. And there's no mutagenic origin to metastatic behavior, namely we don't know of any sort of genes that are going to cause metastases, so I can't really explain that with the somatic theory. And then very significantly, I think, was putting this into experimental form in the form of nuclear mitochondrial transfer experiments, which I'll talk about a little bit later on. So as was discussed earlier, the metabolic theory of cancer, this was first discussed by Dr. Otto Warburg nearly a century ago. And it basically goes over the fact that cancers arise from damage to cellular respiration. So they can't go through oxidative phosphorylation, they have to go through substrate level fermentation. And this is called the Warburg effect, where cancer cells continue to ferment lactate in the presence of oxygen. So there's oxygen present, but they don't use it, or they can't use it. And something that he didn't know about, something that sort of fell out of favor, the Warburg hypothesis, fell out of favor, but that was because he didn't necessarily know about something that Professor Thomas Seyfried found out later, which is not only do they run on glucose and ferment glucose, they also ferment glutamine. And this was sort of the missing link. So different cancers use different amounts of glucose or glutamine to power their cells. So you can take a look at the mitochondria here. On the left is a normal mitochondria, and it has normal cristae, so the inner membrane of the mitochondria. This is where all the action happens. This is where the oxidative phosphorylation is taking place. And as you can see on the right, that's a mitochondria of a glioblastoma, GBM. And you see the cristae are nearly wholly absent. So there's an idea in biology where structure determines function. So if the structure is damaged, the function is going to be damaged. And as you can see, there is no structure of the cristae on the GBM. So how can that possibly go through oxidative phosphorylation if the areas that carry that out don't exist? So that's the idea there. So Dr. Warburg found or showed that cancer cells require about 400 times the amount of glucose that normal cells do. This is because this is a less efficient mode of ATP production, the fermentation process, but also because obviously they have a higher metabolic rate as well. The thing is that cancers don't really run well on ketones, or can't run at all. So if you raise your ketones, lower your blood sugar, get your GKI down nice and low, as was discussed previously, this will reduce and curtail the amount of available energy to the cancer cells but also not damage your own cells. Your normal cells can run on ketones. In fact, some prefer it, like your brain and your heart, your cardiac tissue. Sometimes it's taught in biochemistry that our brain primarily runs on glucose. That's because we're told this fed state is our primary state, this fasting state is a secondary state, and in their primary state, the fed state, our brain is primarily running on glucose, but it also runs on ketones. And that's what's not represented there, is that as much ketones as your brain has available, it's running on those. And so the higher your ketone levels go up, the less and less glucose your brain takes in. And even though glucose is available, it will preferentially run on those ketones. So that shows a preference. That shows that it will choose ketones over glucose when available. So this is just a quick representation of the normal mitochondrial functioning. So ATP largely comes from oxidative phosphorylation through the mitochondria, and very small amount from substrate level phosphorylation. This is an example of is a representation of what is going on inside of a glioblastoma cell. So you can see that almost nothing is coming from oxidative phosphorylation. The majority of it is coming from substrate level phosphorylation, most of that in the form of glutamine. So GBMs primarily run on glutamine. So we say, okay, well, how do we target glutamine? Well, we make it, so that's very difficult to target. We also make glucose. Well, can you limit the amount of eating? So we can limit the amount of glucose that we eat by going on a ketogenic diet. Can we do that with eating different proteins? Well, you can't really avoid it too much because glutamine exists in plant as well as animal proteins. However, it does seem to be denatured in cooking. So that's something that you can address if you want to reduce the amount of glutamine. But generally, that's something that's a good target for pharmacotherapy.
If you want to learn how to implement the ketogenic diet and the Press Pulse protocol into your cancer management, just visit school.com/keto for cancer, the new community by our research analyst Johnny Rockermeyer. Within this new community platform, you can connect with other patients and learn from their experiences. You can also just search through the posts other members have already made. You will have access to our classroom section as well, which provides practical advice and tools for the best results. These sections cover all parts of the Press Pulse protocol that you should implement. Starting with the General Scientific Concepts by Dr. Thomas Seyfried, we will show you how to start the ketogenic diet, including which foods to choose and which to avoid. Additionally, we prepared a list of doctors specialized in metabolic therapy, as well as details about glutamine inhibition and hyperbaric oxygen protocols. So, take a look around at school.com/keto for cancer.
So just briefly, when we look at the different sorts of carcinogenic factors with various carcinogens, radiation, hypoxia, inflammation, rare mutations such as Li-Fraumeni or BRCA1, RAS oncogene, viruses, advanced glycation end products, these all, well, they do many things, but they also attack the mitochondria. They damage the mitochondria. They damage its ability to go through oxidative phosphorylation. And so instead of that oxygen being used for respiration, it's actually turned into reactive oxygen species. And that further damages the mitochondria, further destroys the structure and function, but also causes downstream genetic effects and genetic mutations as well. And so when you are able to address this metabolically, where you reduce the amount of glucose available, you increase ketones, your normal cells are running normally because they have a robust nature. They can adapt to different situations, different metabolisms. And as discussed in previous presentation, this is where you get managed growth. So it curtails the energy available to the cancer cells. It allows your body to run normally, and it suppresses cancer in general. That's the idea. So this is the nuclear transfer studies that were performed by Professor Thomas Seyfried of Boston College, and I think it's quite interesting. So if you take the nuclei of cancer cells and you replace and you transplant them into normal cells with normal mitochondria, They behave as normal cells. You can clone them and get new and actually make little mice and frogs. Not perfect, but they don't turn into cancer anyway. They don't behave in a cancerous sort of way. However, if you take the mitochondria from a cancer cell and put that into a normal cell with normal DNA, normal genes, it does behave as cancer, or they die out. And you can't clone them, obviously. And then if you take the mitochondria, normal, healthy mitochondria, and put them into cancer cells, into tumors, it suppresses the cancer as well. So I think that's pretty, well, it's pretty strong evidence that this is something that's not solely driven by genetics anyway, that there's a strong part to play here by the mitochondria in particular. And this is just discussing the glutaminolysis pathway of glutamine being broken down into ATP, which is a major driver in some cancers such as GBM. So there have been a number of studies, a number of papers, and a number of opinions being put out there that this is something that we should consider as a frontline approach. Obviously, we need more studies. We need larger studies, randomized controlled trials with large numbers. But the idea here is that there's a growing body of information, certainly in animal models. There's quite strong evidence in animal models in a number of different forms of cancer showing very good benefit to survival, and a growing body in human models as well. And certainly we have some very, very significant outliers in GBM that really raises the question of the efficacy. So GBM, glioblastoma, for those who don't know, is a very, very aggressive brain tumor. It's the most aggressive primary brain tumor. It's also the most common primary brain tumor, unfortunately. So from the point of diagnosis, if you don't undergo treatment, standard of care, on average, you will live 3 months. It's very aggressive. With complete resection, and with chemo, and with radiation, depending on your molecular subtype, you can expect to live, on average, about 15 to 18 months. It's very aggressive. So when I'm counseling people, when I unfortunately have to give them this diagnosis, we have to say this is not considered a survivable tumor. This is something that is as soon as you have the diagnosis, you are considered terminal. And that's very defeating for a lot of people to hear. It's obviously very hard to hear that. But one of the first things that they say after the initial shock wears off is, what can I do? What can I do about this? Is there anything I can do? And a lot of people will say, nope, there's nothing you can do. Just eat and drink and be happy and just do whatever. And I understand what they're trying to do when they say that. They're trying to just say, look, enjoy your life and don't worry about that sort of mundane, those mundane aspects. But it really, you look at their face and you look at their body, it defeats them. They think, this is completely out of my control. There's nothing I can do. And of course, there's something you can do. Just being healthier in general, you are going to be able to weather the treatments more, in a more robust fashion. You are going to do better if you are healthier overall. That is going to be the case in any situation. Of course, it's going to be the case in cancer as well. And I think that these studies and the further studies that are in process are, well, they're at least hopeful anyway, and hopefully they do show themselves to be as efficacious as the preliminary studies in animal models are as well. So there's another reason why ketogenic therapy or fasting is of benefit in the role in cancer treatment, because it benefits the standard of care with chemo and radiation. There's a couple studies that came out in 2018, 2019 that showed that fasting and a ketogenic diet showed a protective function towards your normal cells, and were sensitizing to cancer cells. So it made the chemo and radiation more effective to your cancer cells, and also protected your own normal cells from damage. So it had this synergistic effect to improve patient outcomes. So even without the metabolic target, which I think is quite clearly a good avenue of approach, this already shows benefit in many other ways as well. So looking at some of the studies, I mean, there are quite a few just on GBMs. And we won't go through all of these, you'll be pleased to know. But we'll go through some of them and some of the case studies and the particular case reports of these very significant outliers. The research in animal models in particular is very reassuring for glioblastoma. Now, they get the majority of their energy from glutamine. So as you would expect, a ketogenic diet alone shows improvement, but it doesn't show complete survival or complete remission in these animal models, because they're still getting 75% of their energy from glutamine. However, they also included a treatment arm with something called DAWN, which it targets glutaminolysis and restricts the amount of energy that can be obtained from glutamine. And they found that in these studies, there's a series of 3 different trials that Professor Seyfried did, and they showed that reduced disease burden, increased survival, reduced bioluminescence on imaging, and reduced proliferation in the histology when the animals were sacrificed, and they looked at the slides under the microscope, reduced tumor necrosis factor alpha, and also increased the uptake of DAWN, and that's the agent is 6-diazo-5-oxo-L-norleucine, or DON, DAWN. And so again, even without the metabolic effects that a ketogenic diet has, it's already showing that it's beneficial in other ways. So, forget about all the benefits it has of curtailing the energy supply to the cancer cells. It's helping with chemo, it's helping with radiation, it's helping with the uptake of a chemotherapy agent like DAWN. And DAWN was found to be non-toxic. They found that there's a bit of muscle wasting late stage, but that was really it. So, as far as these things go, as far as the side effects of chemotherapy goes, that's pretty low on the list. So these are some graphs and representations from those studies in the mice. If you look on the top left, there, you'll see that the blue line, that is the SDUR, so that's the standard diets, which is a normal chow that they feed mice in the lab, unrestricted. So they ate as much as they wanted, and as soon as the tumors really took hold, they died very quickly. And then the green line there is the ketogenic diet, but using restricted caloric intake of that ketogenic diet. And that has showed a significant improvement already. So just that one intervention showed a significant improvement. And then the red line there is the standard unrestricted diet, but with DAWN. And as you would probably expect, if glutamine is the major driver here, they actually survived longer than just the ketogenic diet on its own. So that's, again, a bit of a proof of concept of this physiological mechanism that we're arguing for here, that this is more wrapped up to do with the energy dynamics of the cell and the mitochondria than really anything else. And so since GBM require more energy from, or obtain more energy from glutamine than they do glucose, then obviously targeting that should have a better outcome, and it does, at least in this study. The most interesting result was just the top of the graph here. That's not just a continuation of that line. That is the combination group of restricted ketogenic diet and DAWN. Not a single animal died. They all survived to the end of the study. It was about 40 days, and they were then subsequently sacrificed so they could look at the brain on histology, and they could do more focused imaging. This middle area here, the top, that is the bioluminescence, so that's the tumor showing up on the standard unrestricted diet. There's the ketogenic restricted diet, so it's less hot spots. That's the combination. That's not a mistake. There's nothing there. So most of them had complete elimination of their bioluminescence. And then on histology, just here, those cells are basically dead. So they weren't able to survive. You completely cut off the energy supply to those cells, and they just died out. And as you can see here, this is sort of representation. Again, this is the luminescence in all the different sorts of mice. Here are the other groups in the KDR. So that's the keto group. That's keto and DAWN. It really, really adds a significant improvement to the outcomes. And that's part of the press pulse idea that Dr. D'Agostino mentioned. So you're hitting them with fasting and ketogenic restricted diet, you're getting their GKI down, you're hitting them with these pharmacological therapies. In the case of GBM, Dawn has been found very effective. It's not approved for humans yet, but hopefully we can get some trials going with that as well. So this is a meta-analysis showing that, well, of all the different sort of animal models. And as Dr. D'Agostino said, there's a number of studies out there. There's a lot more in animal models. Obviously, we can do a lot more and get them through ethics a lot easier than in human trials. But this looked at over 1,200 different references. 38 were included in the review. 17 were included in the meta-analysis. And they found that a ketogenic diet supplementation significantly prolonged survival time, reduced tumor weight, and tumor volume. Obviously, when we say ketogenic diet, some people mean no carbohydrate. I think no carbohydrates when I think ketogenic diet. Some people think 10 grams, 20 grams, up to 50 grams in some studies. And obviously there's going to be a wide range of outcomes if you're doing that in an unstandardized way. You don't really know what's happening. But they did find that the supplementation ratio was best at 4-to-1. So 4-to-1 calories from fat to protein and carbohydrates. So very, very little carbohydrates. Most of that other 20% is going to be protein. So what does that look like if you're only eating fat and protein? That's about 2 grams of fat per 1 gram of protein. That gets you about to 80-20 on fat and protein. As you'll hear from Dr. Chris Kenobi on Saturday, you probably want to use this with animal fats or at least saturated fats because seed oils are not going to be a good idea. So for this study, this was something done by another one of the presenters here at the conference. We'll be speaking later today, Dr. Matthew Phillips. And this was a prospective case series done in New Zealand. And they basically took everyone. So they took people that were palliative, they took people that were recurrent GBMs, and they just said, okay, all we want is that you're over 18 and you can follow this diet. So you don't have any sort of mental health issues or similar that would make it so you couldn't follow the protocol. And they had 10 patients, 5 of which were extremely sick, 2 of which were palliative, as I said. But they showed that all of them had at least moderately improved prognosis. They all went past their expected prognosis. Well, one of the gentlemen, at least at the time of this publication, was still alive. The other had succumbed. This is not uncommon in GBM. Again, this is a very, very aggressive tumor. They were able to keep the GKI down around 3.22. And a lot of the animal models, they try to get below 2 or even below 1 if possible. It's very difficult to do. Sometimes you have to use prolonged fasting in order to achieve that, or use other sort of medications, metformin, other sorts of interventions to try to achieve that as well. And also patients actually staying on the program. This is not easy for everyone. We'll come to a couple case reports later where people had very, very good outcomes, were improving, significantly reducing their tumor burden, and then said, oh, I can't do this. This is very difficult for me to maintain with my social experience, and they ended up coming off and unfortunately dying because of that. So this study in Waikato, it showed the safety and feasibility of this ketogenic approach being done in humans, and the poor prognosis would have excluded half of these patients from other trials. So we do know it's safe. We do know that this is something, maybe it may not be as effective as we see in animal models. However, we at least know it's safe. We're not going to be harming anybody by putting them on this. And we obviously know this as well. Most people here are probably on a ketogenic diet. We have millions of people around the world who've been on ketogenic diets for decades, and we don't see any harmful effects from that. And quite to the contrary, many people here will be presenting on the medical and metabolic benefits of avoiding carbohydrates in general. So this was a retrospective case series done out of Cedars-Sinai. So this has some interesting case reports in it where people actually had significant improvements. Many of them were third, fourth, fifth line treatment by the time they came to ketogenic metabolic therapy. And so they had 5 recurrences of their GBM, of their tumor, and then said, okay, let's try something else. So that multiple rounds of chemo, multiple rounds of radiation, well, to a certain point, you can't go too far with that, and multiple resections. And then some of these people had then come on to a ketogenic diet. Some elected to go on it earlier than that. Here's a list of the ones included in this case series. As you can see just here, everyone at the time of this publication, everyone had survived, were alive, except for these 2 here. And you can also see here, they're the only 2 ones that weren't able to stick to the diet. You can also see here, the red being worsened symptoms, yellow being stable symptoms, green being improved symptoms, that most people actually stayed the same or improved in their symptoms on a ketogenic diet. So I won't go through all these in too much detail, but I think these are particularly interesting cases. The first one is a 38-year-old lady who was diagnosed with a grade 2 spinal cord diffuse astrocytoma, was partially resected, but couldn't get the whole thing. She presented with unilateral weakness. And the interesting thing about grade 2, the lower grade gliomas are more glycolytic, meaning that they require or they use more glucose to glutamine. So you would expect them to be more sensitive to ketogenic metabolic therapy as a standalone, as opposed to having to have a combination with DAWN. And that's really what we found in this, or what they found in this study or this case report with this lady, was she started radiation, became very symptomatic, worsening weakness, had to stop. Started chemotherapy, started getting more symptomatic with that as well, and didn't have any resolution of any of her symptoms or resolution on radiography. So her tumor wasn't shrinking and it was making her unwell. And so she came off of that, went to a ketogenic diet, and within a few months, she started having improvement in her symptoms, and on MRI, regression of her tumor. So at I believe 60 days, we'll look at some of her images later on, that she had a significant improvement in the size of her tumor only with ketogenic metabolic therapy alone. So addressing this with fasting and ketogenic diet, lower glucose ketone index. Case B is one of our unfortunate members that passed away during this trial. It's a 52-year-old gentleman diagnosed in 2013. At first, by the time he went to ketogenic metabolic therapy, he was on his 5th line treatment. He was on a number of different medications, including Avastin, which is, it has a lot of side effects anyway, and it's basically a last line treatment. We give this to people when they're palliative, and they've had recurrence after recurrence after recurrence, then we don't really have many more options for them. So they're put on that. So he was essentially in that category of being in his last stages of GBM. He goes on a ketogenic diet without DAWN, and he started getting significant improvement, started being able to improve his speech, improve his reading, started working out, took dancing lessons. And then after a few months, he said, look, this is too difficult. I'm having all these cravings. I think I want to stop. And unfortunately, his tumor progressed after that, and he passed away. The opposite happened in our next case, case C. This is a 48-year-old gentleman with a left parietal GBM, diagnosed in 2015, had speech issues, speech and language issues, reading problems. He had previously been on a paleo diet, whatever that meant to him, and was put on a 3-to-1 ketogenic diet, so 3 times as much calories from fat as opposed to protein. After 2 months, he started having improvement in his memory, in his speech, in his reading, and overall was doing much better, and found after 6 months that there's actually demonstrated improvement on his MRI. So the contrast enhancement that we associate with a high-grade glioma, a very metabolically active tumor, was now not to be seen on his MRI. So we had resolution of his problems. And he was, again, one of these late stages. He'd been, it's his third round of treatment at this point. So he's not a brand new diagnosis or anything like that. It didn't get to him fresh. He was already pretty battered from surgery and treatment. He's still alive, or at least at the time of this publication, and he was happy to continue on with his diet and continued to do very well. Case D is another one of our unfortunates. It's a 27-year-old man who's previously vegan, and unfortunately found it very difficult to transition to a ketogenic diet. He was also being put on dexamethasone, which is a steroid that can artificially raise your blood sugar, basically causes diabetes. And that's very difficult to manage your blood sugar and ketones, obviously, when you're on a medication that jacks up your glucose and suppresses your ketones. But he was able to get into ketosis. He was able to eventually get into a therapeutic range, and he improved. He again improved his speech and language issues, improved his reading issues, started working out, started being more active, started competing in gaming competitions, and found that on his MRI, again, had reduction in his tumor size. So he had clear radiological evidence of improvement on this diet. Unfortunately, he found that adherence was very difficult during his social outings, and he elected to stop, and he died within the year after that, after demonstrated reduction in his tumor size on the treatment that he was on. The next three cases, I won't go through all of them, but they are examples of glioblastoma patients on their third, fourth line treatment, went onto a ketogenic metabolic therapy, not even addressing glutamine, and they all improved significantly symptomatically, radiographically, and were still alive at the time of this publication. Here's some of their imaging. So this is objective evidence of the efficacy. So there you see that enhancing lesion there, and here after 60 days, it's much, much smaller, right? Here, that's our case 3. That's the gentleman who was able to stay on his ketogenic diet, was doing very well with that. So you see that ridge there that lights up a bit more. That's that area of contrast enhancement in the resection area, in the resection bed. And then after 270 days, there's no enhancement whatsoever, right? I mean, I'm sure there's still cells in there. It's very difficult to get rid of this stuff. And as we see with the other ones, even when they removed enough that they couldn't really see it, appreciate it on MRI, they still came back. So there's almost certainly a disease process still underlying this. However, it's clearly going in the right direction. This was case D. That was the unfortunate gentleman who had been vegan, and that's again the area of enhancement there. And as you can see there, after 60 days, there's absolutely no enhancement. It's resolved. And after he stopped, that came back and he died. And this is our lady with the spinal cord lesion that you can see there, and then not really anything there after 60 days, and sort of a different weighted imaging there. Again, you don't really see too much after 60 days. So this was a systematic review specifically looking at malignant gliomas. They found back in 2021, there were already 6 published studies in humans. There were 10 in progress. There are more now. And they showed that this was a feasible, safe intervention in humans, that this wasn't going to cause any harm in any case. They concluded that this shows good efficacy in animal models. And even though the human models were few and limited, the safety and feasibility was shown in these cases. A lot of these things were smaller studies, sort of 8 to 20 patients. There was one randomized controlled trial, but again, these things don't necessarily go on long term. They're picking these things for 16 weeks or 60 days or a certain set period of time. And obviously, it'd be better to get larger, longer studies that would give us better information. This was another case series with 16 patients that came out of Arizona. And what I think is striking is just the dramatic difference in the radiological findings here. So that's all swelling, really. This is all inflammation and edema, but you see here it's massively reduced. And you see here, there's that contrast enhancement there. That means there's tumor there, much less there, much reduced. This again, a lot of edema, a lot of swelling, tumor in there as well, and then much less. And you see this throughout all of these different examples of all these series. These are all improving dramatically, and they found, as you would expect, that this improved survival, improved symptoms, and improved overall management of these glioma patients. Not all GBM, but high-grade gliomas mostly. So here are some of the outliers, the significant outliers that demonstrate what we're talking about here. Some of these people actually didn't even undergo standard of care, or if they did, it was for a very short period of time. This is a patient out of Hungary, and they presented with headaches and found that this had this very large lesion, this big, large cystic lesion here, had a lot of midline shift pushing the brain over. That's life-threatening. You have to operate on that person very quickly, or they will die just from the pressure on the brain. So this is post-resection. Midline shift is very resolved. They were put on chemo and radiation, and unfortunately, several months later, 5 months post-op, it's actually recurred already. So now you have this recurrence of this cystic lesion in the brain. At that point, she said, I'm not doing this anymore. This is clearly not working. And she found Paleomedicina, which is a group in Hungary that does this sort of thing. And they do what's called a Paleolithic ketogenic diet. Basically, no carbohydrates at all. And they take it one step further and say, don't eat anything that didn't exist 20,000 years ago, right? And so how much is left? What plants do we eat now that existed 20,000 years ago? Not really many, and this ends up being what her diet is. It's basically a carnivorous diet: braised calf liver, pork, more pork, and pork. And she found that at the time of progression, since then, her disease completely halted, and in fact has been regressing. So this is a series of her MRIs. This is at 5 months post-op when she started, and then 1 month, 5 months, 11 months, 17 months. Slowly but surely, it's coming down. And so at the moment, I understand that she's still alive. It's nearly 7.5 years now that she has survived without any adjuvant treatment. She has not gotten further resection. She has not had chemo radiation. In fact, she found it didn't work for her. So she said, why bother? And she's still around. So that's a significant outlier. Remember, without treatment, you are supposed to live 3 months. Now, she had partial treatment. She had surgery. She had a subtotal resection. So they didn't get all of it, but they got a lot of it. They at least reduced the pressure. And then she had a round of chemo and radiation. Didn't work for her. Tumor represented. And that's when she stopped it. So she had some treatment, but not for the last 7 years. This is a gentleman, a very nice young man. This is someone that you might find on my podcast and my YouTube channel that I interview. Is a gentleman named Pablo Kelly. He's a very nice guy. His case was written up by Professor Seyfried, and he at this time, he was an 80-month survivor, so 80-month survivor, so one of the longest documented survivors of glioblastoma in the literature. He presented with seizures, had this little lesion here, and going there. And they took a biopsy, they found it was indeed GBM. So as far as GBMs go, this wasn't the most aggressive form. It was a IDH mutant, and that's thought to be not as bad of a one. So instead of 15 months, you might make it 18 months. So much better. He looked at that and he just said, I don't think I want any treatment. That's not a good prognosis. That's not good enough for me. I'm going to look at something else. He came across ketogenic metabolic therapy, came across Professor Seyfried's work, and decided to make a run at that. And just with diet alone, so no chemo, no radiation, hadn't even had surgery yet, only had a biopsy. He survived another 3 years, and it very slowly increased in size. So you see just here and just a little bigger there. At that point, he did elect to have a debulking. So they went in, they debulked the tumor, and then he went back to just eating the way he ate. No chemo, no radiation whatsoever. And he's sort of in that equilibrium now where it's not really growing, it's not really getting out of control. He's able to keep control of it. He's able to manage his disease, which, with this sort of thing, sometimes is the best you can do until we maybe get other agents such as Dawn, that if we can show that to be efficacious in humans, we might actually be able to, knock on wood, somebody. But he's still alive. So at the time, this was 80 months, but that was in 2021. This is another 2 years on. So he's around 9 years now, a 9-year survivor. Again, without treatment, you're supposed to be dead within 3 months. He has not had treatment, just a debulking 3 years on, but no chemo, no radiation. He's 9 years on. And you can see how lucid he is on when I interviewed him. He's a very nice guy, very intelligent. He has a wife and kids. He lives a more normal life than you would expect for someone with this disease. He still suffers with seizures occasionally, but he's not even taking any medication. He's controlling this completely with diet. And as he says, he's not even all that strict, and that tends to cause problems. Then he says, okay, well, look, I need to buckle down and get a bit harsher on myself. And then he starts getting better results. This is a patient, it's a bit sad actually. So this patient was in Egypt, had again a GBM IDH mutant, just like our friend Pablo. And he aggressively went after ketogenic therapy and fasting. Preoperatively, the tumor had already shrunk by the time they got him into surgery, and they found that he improved very well. So you can see these images here, and here. So they debulked, but then they had a little bit, but it still didn't have the progression that you would think. It actually went better. Now he did get some standard of care, and he got radiation as well, and that was unfortunately what did it in for him. He died of tumor necrosis liquefaction. So the complication of the radiation, he actually died from that, not the tumor itself. And this was a lady who had very, very good control. So I'm going to sort of gloss through these things because I know we're running out of time. This was a lady who had extremely good control of her GKI, kept that low, was eating a very restricted ketogenic diet of about 600 calories a day, had very good control, actually showed radiological resolution on her imaging, and then for some reason decided that this wasn't tenable, she couldn't keep this up anymore, and so she stopped. And in some months later, the tumor represented, and she was put on Avastin, and she ended up dying from complications of Avastin. So that's her progression here. During this time, you can see very good control with a restricted 600 kilocalories a day, sort of low-calorie diet. At this point, she sort of stopped, and that's a very quick progression until she passed away. This was another lady who was actually quite significant. This tumor was found to be inoperable. It was just in areas of the brain you just cannot resect. You just die from it, or you'd be so debilitated and disabled that it wouldn't be worth living. And with ketogenic diet and supplements like metformin, she ended up controlling this for about 7 years. She refused all chemo and radiation. She was offered it at 5 different institutions. She refused all of it. And she was still driving, functioning normally, but it was slowly progressing. And eventually, after 7 years, it got away from her. And you can see here, she sort of lost control. Now, is that because she was a bit more symptomatic and couldn't really stick to it anymore, or did that lead to her becoming more symptomatic? It's unclear. This is a very interesting young man named Andrew Scarborough, who I've also spoken to and interviewed, that people can go and look at his story. He's very interesting because he is probably the longest living GBM survivor in the world. And he had a very aggressive kind. So he had an IDH wild type unmethylated MGMT glioblastoma. So that's the most aggressive form of the most aggressive form of brain tumor. He had a partial resection, so just a debulking. Weren't able to take all of it. And then he started chemo and radiation, but when he got his moleculars back and he realized there's no real hope here for chemo and radiation, he went down a different angle, again found a ketogenic diet, and is now alive 10 years later. He's earned advanced degrees. He's written a book on gadolinium use in MRIs, and he is actually conducting his own studies in humans for ketogenic metabolic therapy and glioblastoma. Very quickly, this is a thymoma. This lady was given a year to live. She said, not doing it, and she went on ketogenic metabolic therapy, and within a few months, the thymoma had completely resolved. 3 years later, it's completely gone, and she's still alive. This was a lung tumor that metastasized to the brain. They have these massive lesions all over the brain, non-resectable, hit it with whole brain radiation, couldn't radiate the chest, and went on ketogenic therapy for 10 years, complete resolution of his tumors, as you can see in those images. And at that point, he had dyslipidemia. His doctor says, you're going to die of a heart attack. Like, well, he was 10 years ago, he's going to die of brain tumors. And so he came off. But now 3 years later, at the time of this reporting, he was still alive and didn't have recurrence at that point. So very good result. Current human trials, this is something that's going to be discussed by our friend Dr. Matthew Phillips later on today, who did that prospective case series. He's now doing a larger study with more patients and as an interventional trial, and really aggressively hitting people with ketogenic therapy and diet and fasting in order to get that GKI down as low as possible and get people as good of an outcome as possible and try to standardize our treatments. And this is just discussing the study being done by Andrew Scarborough at Charing Cross Hospital in the UK. He's looking for different metabolic phenotypes and markers in normal adults versus GBM adults, and then at that point putting them on a ketogenic diet treatment arm. And then Professor Seyfried is trying to standardize the KMT guidelines for GBM in particular. And so this is something that he's getting ready to publish. I've seen it's like 100 pages long. It's massive, but it's very, very good. It's very, very clear and very standardized, saying this is how you address all of these things in these situations. And as he says, genetics can vary between tumors, but phenotype and fermentation is common to most. And so addressing this aspect may prove a beneficial adjunct to standard of care. And ketogenic metabolic therapy has been shown efficacious in numerous animal models and an increasing number of human trials and studies, but to varying degrees. They've all had different forms. They have different amounts of carbs, different amounts of different sorts of food and things like that. So of course you're going to have, you're not going to be able to trust the data really. There was just one last study. It was a Professor Hugh from Cedars-Sinai that we discussed one of his trials earlier. He was put forward a phase 1 trial with a phase 1 trial with 14 patients, put them on keto, showed that it's possible to do this. They had a 70% improved outcome and doubled the median survival of the patients. And now he's getting into a phase 2 trial where he's trying to recruit about 170 patients over 5 institutions and do this for about 2.5 years. The first phase 1 trial was only over 16 weeks. So it was a shorter, smaller study, and it was already showing benefits. So now they're doing a larger study with longer time, and I'm very much looking forward to that, because obviously that will give us some very good information and really show us if we have something here to work with.